So HIV prevalence is not particularly high in Pakistani women. There may be subgroups of professional sex workers in whom it's higher, but the average Pakistani woman's probability of having HIV is fairly low. So when we have outbreaks, all of a sudden in pediatrics, it can only be from one source. It can only be from unsafe needle use. And this has been a chronic challenge in Pakistan, is reuse of needles that have been used in someone else. And we believe that hepatitis B and hepatitis C have been routinely transmitted in this way, one of the reasons why those hepatitis viruses are common in Pakistan. Not the only reason, but one of the reasons. And HIV outbreaks in children of the magnitude that we're talking about in Larkana and now the new outbreak, these are exceedingly likely due to the repetitive use of needles for vaccination, for clinical care, for whatever. And getting a handle on this is going to require systematic attention to logistics of provision of non-reusable needles and syringes, perhaps the use of syringe devices where once they're used, they lock and you cannot reuse them. Children tend to be a dead end for transmission. So if a child gets infected, the child is unlikely to affect others. There are very few routes in which that can happen. So it tends to be the burden of the child, but it doesn't contribute to the transmission cycle. A man getting infected can infect another man or can infect a woman. A woman getting infected can infect men. That's probably less frequent in Pakistan, woman-to-man transmission, because of circumcision. So male circumcision is extremely high in Pakistan because of the religious commitment to circumcision. And we know that that reduces the susceptibility of men to HIV. This is well documented, both in heterosexual men and even in men who have sex with men. So the fact that we have near universal circumcision of men in Pakistan reduces the efficiency of transmission. So even an HIV-infected woman, the man is less likely to get infected. It's possible, but less likely. And then male to male is a little more efficient than female to male or even male to female. So then we do have a problem in MSM. We've had tremendous success in prevention of mother-child transmission worldwide with screening in pregnancy and transmission from mother to child being interrupted. With SARS-CoV-2, it's a respiratory transmitted infection. There was some question whether there could be perinatal transmission, and that turns out to be trivial compared to the magnitude of respiratory infection. So at the end of the day, a sexual and blood-borne transmitted virus is fundamentally different from a respiratory virus, and the lessons learned are not as substantial. We do think, though, that one has to think about SARS-CoV-2 in pregnancy, and one has to think about risk to children. And of course, we have something for SARS-CoV-2 we don't have for HIV, which is a vaccine. So it was a quirky kind of question that came out from the curiosity of one of my students, and we thought we would look into it to see if there were any gems to mine, and you can make your own judgment from the manuscript whether it was worth doing.